All right, good morning. Today we are going to talk about the suicide risk assessment utilizing the Columbia Suicide Severity Rating Scale. We've had some issues in several facilities lately that brings this topic back up to the forefront. Also, while Brookwood has been using the full suicide severity rating scale for quite some time, it is new for Epic users. So we will go through that a little bit, but it's a good refresher to everyone to make sure that we're not missing anything in this patient population. So this is that pre-screen that is done on every patient that is triaged in the emergency room. So when you do the triage, this is where you're doing the Columbia pre-screening. Those questions of, is the patient 5 years of age or older? Can the patient be assessed? Now I want to stop right there for just a moment, because if that patient rolls in and they're obtunded, they're unresponsive, it's a drug overdose, it's something of that nature, and they clearly are unable to be assessed, that's not the end of it. So what our policy says is that every hour we should be reassessing that patient to see, can we assess them so that we can see where they are in that. And it's reasonable that that might not occur while they're in the emergency department. That might not happen until they get to the ICU that we're able to truly assess them. But we should be trying, and at some point, if we can, go back and finish the screen. Then it says, does the patient present with a self-harm intent or show signs and symptoms of self-harm? So looking at, is it an overdose? Is it, some of those obscure things like maybe cutting, lacerations, things like that, that we might should look at a little bit harder to see if these are self-harm intents. And then does the patient present with a behavioral health chief complaint? So get my screen work here. The policy, which I mentioned before, is what is driving us with this screen, as well as continue to try and get that assessment done as quickly as we can. Now, hopefully you recognize this a little bit. This is that trigger tool that we utilize and put up the triage in the places, and hopefully it's still there. But this is just a guide. So if you checked yes, or when should we check yes, if that patient is here for a psych eval or admit to psych unit, medical clearance for admission, detox, we should be clicking yes to presents with a behavioral health chief complaint. And what we're seeing is more often than not, we're clicking no on those. So we need to make sure that we are clicking yes to presents with a behavioral health chief complaint if they're here for psych eval, clearance for admission, detox, and then obviously those other diagnoses that would lead us down that path, things like bipolar disease, depression, anxiety, schizophrenia, any of those. Obviously, we're doing it. We don't miss the suicidal homicidal ideation, but it's those less obscure ones that sometimes we just kind of go so fast and move right past. So don't forget the hallucinations, the delusions, the erratic behavior. Maybe a patient comes in because their mother brings them in for erratic behavior. That's a behavioral health chief complaint. So we need to make sure that we click yes there. Substance abuse. So this seems to be the big one that we miss. So when they come in for substance abuse, alcoholism, use, what case may be, that is a behavioral health chief complaint, because maybe they're drinking because they're depressed. Maybe they took the pills or whatever the drug may be because they wanted to harm themselves. And so we need to do that deeper dive into those patients when they come in to ensure that we're not missing them. Anything looks to you that it could be a behavioral health chief complaint, then we want to go yes, which will open up those other questions, obviously, but it gives us the opportunity to not miss some of these in our patients. So there's that Columbia Suicide Risk Assessment. This is that short version. This is if you clicked yes to self-harm or yes to behavioral health chief complaint. Then it will open up these questions. Does the patient wish to be dead? Do they have suicidal thoughts? Some of the nurses that I've spoken to, when we start looking at this and digging into, what are you really thinking when you're asking or answering these questions? And some have said that if there's not a clear plan, or if there hasn't been a intent, then they don't consider it a suicidal ideation. So that's where this comes into play. Suicidal thoughts. I've just thought about not wanting to be here anymore. We're going to click yes there, because that's exactly what that is. If you look at the next questions, it gives you the opportunity then to say, that they had thoughts, but they don't have a specific plan or any intent to act on it. Because their next question, that follow-up question to, I just don't want to be here anymore, should be, well, have you thought of harming yourself, and how would you do that? And if they were to say, well, I don't really know, I just don't want to be here. Well, they don't have a clear plan or intent. The next one, suicide intent without specific plan. So yes, I want to die, I would like to overdose, but I don't have any pills, or things like that. Versus that suicide attempt with a specific plan. Yes, I took the pills, I plan to run out into traffic, those types of things. Then there is that suicide behavior question. So maybe they're telling you, no, I don't really have a plan, I don't have an intent or any of that, but they've given away all their belongings, a family member tells you. They've written a note, they're starting to get things in order. They posted something on social media. That's going to trigger that question. So that's really how we should be looking at that. And in EPIC, if you're thinking, I don't, how am I supposed to know what these questions mean? If you click at the top of the screen of EPIC, the box that says show row info, it gives you detailed instructions of what those definitions are. And then how long ago did any of these? So has these thoughts been recent, or have they been long-term? Keep in mind, LPNs cannot do this screening, and so it will have to be the RN that does this screen. This is what it looks like in Cerner. So I just want you to know we're using the same questions. This is an evidence-based tool that is used nationally. It's even on the Joint Commission site. So we're using the exact same questions. It just looks a little different, obviously, from our different EMRs. So when we do the screening, those yes responses, depending on what questions we're talking about, whether it's wish to be dead versus have suicidal thoughts and intent, kind of guides us as to what kind of care they need. But as you know, they say that in the ER, they're one-on-one. So they become under constant observation. Sorry, it's going on its own. And they become that high risk one-on-one patient. So don't forget the order. The order needs to be placed for that. So that triggers you there on that BPA, as well as the patient safety checklist is the next thing that we're going to do. So it is in your ER record, in that ER narrator. You can find it elsewhere. But that patient safety checklist is what is the first thing that we need to do. And that is that, we're ensuring that the room is made safe. Most of the rooms are not going to be considered psych safe. So this is our checklist saying and helping us remember what we need to do in order to make that room safe. Removing ligature risk, removing trash can liners, removing as much things as we can out of the room so they are not risk. And that's your documentation. You also have your violence risk and elopement risk if that applies to that patient. And those should be done once a shift. So in the era right now we're in of boarding patients for long-term in our emergency departments because of the lack of beds across our state, then we would redo those assessments each shift. Now, the full assessment, because all we're doing is this screen. So if that screen is positive, we're putting them in the emergency room on a one-to-one constant observation at that point. They're going to stay on a one-to-one constant observation until that full assessment can be done by who has been designated as the qualified medical professional or mental health professional for your facility, or the physician either does that assessment or Psych sees that patient. Please remember, for those hospitals that do not have full-time psychiatric coverage, you do have telepsych readily available, and you would want to kind of remind or nudge your physician sometimes to let's use that, particularly on patients that we don't have beds for, and they're going to be down there for an extended amount of time. For patients that we think are malingerers, you know what I'm talking about? The patients that come in and they kind of know the system, and they know that if they say they're suicidal or homicidal, then we have to keep them. We have to be very careful about those, because that's where we tend to get some of our bias, in that you may even know them. So you may see them routinely and this is what they do when they need to come in for a place to stay or whatever that may be. But you cannot dismiss them because of that. We still have got to do all of these things that we would do on any other patient, because we never know when might be the moment or the trigger to when they're going to leave us and then commit some sort of act. And then, as you know, we're going to be liable and responsible for that if that does occur. So don't get tripped up with those patients that you feel like you've seen routinely and you don't really feel like that they mean it. It's really not for us to decide. Now, this assessment could, however, help take them off one-to-one, and Psych, if we get telepsych or the psychiatrist to come and see them, they could discharge them if they felt like they were not truly suicidal. So let's talk a minute about who that is in the facilities. It's different everywhere. Brookwood has their Psych rapid response and their Psych services that would be able to provide that service on patients that are held for any length of time in the ER, or it can be done when they go upstairs. Princeton is going to be house supervisors with some help from Psych staff. Shelby is going to be some Psych staff, certain nurses, social workers, and potentially some backup from house soups if needed. Walker, your charge nurses in the emergency department are trained. So Psych is available to help if they can, but if they're not able to come down, then your charge nurses in the emergency department have been trained and they can do that assessment as well. And then for citizens, house soups and some assistance from Psych, if available, will be able to do those assessments. So that's really what you're looking for to be able to get those assessments done. Otherwise, they stay one-to-one. It may change them to a line of sight, which is a little bit easier to manage in the ER. Now, if you're looking for that full assessment, so if you do end up at a place that has to do it, or somebody comes to do it for you and they don't know how to find it, if you go to flow sheets, and now for ER, we don't do flow sheets, so you may have to use a little arrow here to drop down and choose that rarely used option, and then you'll see flow sheets. Under flow sheets, if you will type in the search bar here, the CSSR, that is for the Columbia Suicide Risk Assessment, then here you'll find it. And it is that lifetime recent one is the one that you're going to do. Now, I'll say this, if you end up having to do it or help with it in the ER, know that these questions are very detailed. It is a lot more in depth, and it is going to ask lifetime and recent. So that's 2 questions. So, and if they're here for recent, well, then you've got lifetime. But have there been other attempts, other thoughts, other plans, other issues? Lifetime. And I know that's not how ER nurses tend to think. We think about right here, right now, what are you going to die on me today? How do I take care of you? But in this instance, we're going to have to look at the bigger picture, and that's going to help us be able to score these patients more appropriately. When it scores out, then that's going to tell you what they need. So if they're low risk, you're just monitoring them every 15 minutes, because that's what Psych does. Every patient on site, they're on Q15. If they're moderate risk, then they could be line of sight at every 15 minutes. And then if they're high risk, that's that constant observation, one-to-one patient. So it will give you the scores. You do the assessment, it scores it out, and then it tells you high risk, moderate risk, or low risk. A reminder here, if they do that, so whoever is able to do that in your ER does the assessment on the patient, and we've had them one-to-one, and now when they score out, they score 15. So now they're a moderate risk. They can be placed on line of sight. The order has to be changed, because the current order in the system should be constant observation, right? So we need to change that to line of sight. So make sure that order is put in for that physician. And that way, if the charts ever looked at, our level of observation and our order match each other, which is going to be key there. So make sure that that order gets changed if that happens. So the policy is there. So if you like to look at the policy to see what it is, I just wanted to reference that for you. There's that policy number that you can look up in policy text. Now, the other thing that I wanted to talk about today is, what if it is that patient that, for whatever reason, there's a disagreement about what we should be doing, what is appropriate with a team member. And that could be a physician, it could be the house supervisor, it could be your coworker that maybe they don't think the patient should be on that level. Maybe it's the other way. They're trying to restrain a patient who we can't restrain. So this is a model that we've used where you we say you get to cuss at work, but I don't mean profanity, obviously. Cuss is an acronym, and it's a way to stop the line if we think that maybe things are not going exactly like we should. And that is, I'm concerned, I'm uncomfortable, and this is a safety issue. So I don't feel safe in this instance. And that should get everybody's attention, because if we all look at this and we all get used to using this terminology, then when you say that, then it's going to take give people a minute to stop and go, okay, hold on just a minute. So this goes into it a little bit more. So C is state your concern. I'm concerned. So describe the specific behavior. In this instance, I'm concerned that we're letting Mr. Wilson go home, although his heart rate is fine and he's not getting and shortness of breath. His blood pressure is elevated. He's complaining of tightness in his chest. So obviously, I'm concerned about this patient. U, again, is uncomfortable. So identify some consequences. I'm afraid he might be headed for another MI. If we let him go, he might go home and have a heart attack. So he lives alone, nobody will find him. And then the S is for it's a safety concern or a safety issue. So make your request. I'm uncomfortable with him leaving. He lives alone. It's unsafe. Can we reevaluate the situation so that we do it appropriately? I can tell you in my experience when I first started nursing, so that's been a long time ago, we had a lady who came in all the time to this facility and saying that, she was suicidal because she knew that meant we had to admit her, and that did two things. It gave her a place to be, and her family would come and she would get the attention. So this was during a busy time like we're in now. Well, I guess we've never been anything like we are now, but a busy time. She comes in the emergency room. She's there for a day and a half because there's no beds. Psych comes to the ER. They see her. They decide that she's okay to go home, that she is not a danger to herself or others. Of course, she has no way to get home. Nobody will come and get her. So we get her a cab to take her home. So I am wheeling this lady out in the wheelchair, and she has a lot of comorbidities. So she has one of those big Ziploc bags full of meds, right? So we're rolling to the cab. I'll never forget this woman. She steps to get into the cab, and she turns around, looks at me, and she shakes that bag of medicines at me, and she says, "I'm taking all of these when I get home." And I'm gonna be honest. I took a breath and I started to say, "Okay, you be careful going home now." But I thought, this is going to be that one time that she actually does it. And of course, this cab driver is going to say, well, that dark-headed nurse heard her say it. So knowing what was about to happen to me going back in, I put her back in the wheelchair and I rolled her back into the emergency room where the physicians nor my teammates were happy with me at all. But what do you do? And that's that instance we're talking about. So she just didn't want to go home. And I get that. But if she had gone home and taken all those meds, then we're liable for that. So she had to come back in and be re-seen to be then decided because she's made another gesture. So that's the kind of stuff that we're talking about. So if it is something like that, so if the physician has said, I'm not seeing her, we're not doing this, then that's when I would have used that cuss mnemonic, and where I can say, I'm concerned. What if she does do it again? If she takes all these pills, nobody's going to find her. I'm uncomfortable letting her go, and it is a safety issue. And then if I needed to, I could go up the chain of command at that point. But probably most likely when you point out things like that to people, they know you're right. I mean, you're busy and you're tired and you just want to move on. And we all understand that. But when we catch each other, remind each other, we know what the right thing to do is. I'm going to see if this video will play on the shared screen. And it is actually an ER setting where they utilize the cuss method. It's not very long. So let's watch this. Eddie is the patient. He's a frequent flyer for shortness of breath. Let's see if we can hear. So you can see in this that this is a patient they take care of on a routine basis. They know him well. And so it'd be very easy when you're very busy, like the physician was, to just move on. But because the nurse was able to say, I'm concerned, those words stopped him. And then he was able to tell him why, which painted that picture. It does have a lot to do with the rapport that you have with that physician to be able to do that. But that is just one way that that CUS method is utilized to be able to show that and have better outcomes for our patients. So that's really what we want you to think about when you're taking care of these patients, so that we don't miss these types of things. That's about all I have. So please let me know if you have questions or concerns about any of this. Make sure that you're using that screen at triage and you're asking those questions. And I know we get to moving kind of fast and clicking kind of fast, but make sure that we don't miss those behavioral health chief complaints. And then the last thing that I want to say, that I know that is at triage, but if you have that patient that maybe was there for something else, maybe was there for abdominal pain, and it is not until the end that they make a comment or something of that effect, you can go back and do that screen then, and should go back and do that screen. So if they say something that they have not said the whole time they were there, and now they're saying it, then you go back and you do the screen, which will then open those other questions, which will then move from there. And then that helps you to be able to have that conversation with that physician, to be able to make sure that we're stopping the line appropriately and we're not letting one of these patients go and something horrible happening. So let me know if you have questions, any concerns, and I look forward to seeing all of y'all soon. Have a great day.